I'm Chris, 20 years in healthcare, the last decade working with cloud and AI. I'm the healthcare AI architect. This is where healthcare meets practical technology. If you're leading a hospital system today, AI isn't a future discussion, it's an operating decision right now. I'm the healthcare architect. I look at technology through one lens: business impact. Here's the thing: the cost of inaction is rising faster than most leadership teams realize. Not just in missed savings, not just in clinician burnout, in what I call integration debt. Integration debt is simple: the market moves, your workflows don't. Every quarter you delay makes the eventual transformation more expensive, more disruptive, and harder to govern. Right now, healthcare is under pressure from every side: margin compression, staffing shortages, higher patient expectations, growing documentation burden, board scrutiny on quality, access, and efficiency. AI sits directly in the middle of all of it. The strategic question isn't, should we adopt AI? That question is already outdated. The real question is this: can your organization build a responsible AI integration framework before inefficiency becomes structural and competitive disadvantage becomes permanent? Because organizations that move now can compound gains in three places: lower administrative cost, higher clinical throughput, better consistency in patient outcomes. And organizations that wait, they'll inherit fragmented tools, rising resistance, unclear governance, and a more expensive catch up phase later. So, in this briefing, I want to cover three things. First, the business case in executive terms: revenue, cost, and quality. Second, the strategic timeline: what belongs in the first 90 days, what takes 12 months, and what sets the 24-month foundation. Third, the hard part: human adoption, process debt, and governance. Because AI in healthcare isn't a software purchase, it's an operating model decision. Let's start with the business case. To understand why AI is a strategic necessity, we must look at how value compounds across the entire operating model, from the back office to the bedside. Let's start with the primary value drivers. Administrative streamlining is the first value driver: documentation, scheduling, billing, prior authorization support. These are not glamorous functions, but they are large cost centers. They also create friction that bleeds into patient experience and staff morale. In high volume workflow areas, conservative models point to 15 to 25% administrative cost reduction potential. That matters. But the bigger point is what that reduction unlocks. When repetitive work is automated, labor capacity can be reallocated to higher value tasks. Staff spend more time resolving exceptions, supporting patients, and stabilizing care coordination. That is not just cost control, that is workforce leverage. The result: lower operating expense and better labor utilization. Clinical workflow optimization is the second value driver. In radiology, pathology, and other diagnostic functions, AI assisted screening and prioritization can reduce time per case, not by replacing specialists, by helping them triage faster, surface anomalies earlier, and focus attention where it matters most. This creates 10 to 20% efficiency gains in imaging and laboratory services in many scenarios. For leadership, that means capacity expansion without proportional headcount expansion. And in a labor constrained market, capacity without equal labor growth is strategic gold. The result: higher throughput and stronger margin protection. Resource utilization is the third value driver: bed management, equipment scheduling, staffing allocation. These are classic coordination problems, and hospitals still lose money every day to idle assets, delayed placement, and uneven staffing loads. Predictive analytics can help forecast volume, optimize scheduling, and reduce avoidable delays across the enterprise. This is where AI starts to impact flow, not just tasks. Flow, and when flow improves, length of stay pressure eases, bottlenecks reduce, and asset productivity rises. The result? Better use of fixed assets and improved enterprise efficiency. Now, let's talk about the part executives should not underestimate. AI is also a quality lever. This is where the conversation shifts from automation to outcomes. AI driven diagnostic refinement can improve early detection for high morbidity conditions. Treatment protocol optimization can reduce variation in care delivery, and variation, as every executive team knows, is where quality gaps, safety risks, and unnecessary costs often hide. In oncology, cardiology, and chronic disease management, this matters directly. Earlier identification, more consistent intervention, better alignment to evidence based pathways. And when care variation decreases, the financial benefits often follow. Fewer avoidable escalations, better quality scores, stronger reputation. So the business case is not cut cost with AI. The business case is this: use AI to improve operating efficiency, expand constrained capacity, and raise the consistency of care. That is a strategic platform, not a tactical tool. Urgency without structure is just chaos. We need a sequenced approach that earns the right to scale by proving value at every milestone: 90 days, 12 months, and beyond. Now let's move from value to timing, because urgency without structure creates risk. In the first 90 days, the goal is not enterprise AI. The goal is foundation. That means four things. First, form an AI governance committee, not as symbolism, as a decision body with clinical, legal, technical, compliance, and executive representation. Second, conduct an organizational readiness assessment. What data is usable? Which workflows are stable enough for augmentation? Where are the trust barriers? Which teams are prepared to pilot? Third, identify 2 to 3 high impact, lower risk use cases. Think administrative documentation support, scheduling optimization, or non invasive diagnostic assistance, where measurement is possible and risk is controlled. Fourth, establish the security and compliance baseline: HIPAA controls, vendor review standards, data provenance requirements, accountability for model outputs. These are not overhead tasks. They are what prevent expensive missteps later. The result? Lower deployment risk and faster path to scalable ROI. From month 4 through month 8, move into pilot deployment. This is where many organizations make a mistake. They go live too fast, too publicly, and too broadly. A better model is shadow mode activation. Run the AI in parallel to existing workflows. Compare them to actual decisions. Measure accuracy, usefulness, and integration fit before introducing patient-facing reliance. Then run structured clinician and nurse focus groups. Not once, repeatedly. This is where trust is built. Clinicians need to understand what the tool does, how it was trained, what its limits are, and how their feedback changes deployment decisions. That reduces black box resistance and improves workflow fit. The result: higher adoption and lower implementation friction. By months 9 through 12, scale what works, expand the successful pilots, launch broader training, implement continuous performance monitoring, add bias auditing, document governance decisions and lessons learned. At this point, you are no longer testing a tool. You are establishing an organizational AI framework. And that distinction matters because frameworks scale. Point solutions do not. The result? Repeatable deployment and enterprise level value capture. Then there is the 24-month signal. This is where leaders need to think beyond the first wave. The organizations that execute well in year one will be positioned to integrate more advanced capabilities later. Generative AI in administrative support, smarter clinical summarization, edge enabled intelligence closer to care settings, more mature decision support ecosystems. But none of that is sustainable without the foundation. If your governance is weak, scale creates risk. If your workflows are unstable, scale creates noise. If your clinicians do not trust the systems, scale creates resistance. This is the hardest part. It is not about the software, it is about the organization. Trust, workflow friction, and leadership readiness are the real architects of success or failure. So, yes, move with urgency, but move in sequence. Now we arrive at the hardest chapter. Not the software, the organization. When AI feels like a black box, adoption stalls. When recommendations arrive without explanation, skepticism grows. When clinicians cannot see how data is handled, resistance hardens. You do not need to give clinicians a machine learning course, but they do need enough visibility to understand where training data came from, what the model can and cannot do, and how to interpret its outputs. Trust is not a marketing problem, it is an adoption prerequisite. The result? Higher clinical buy in and faster time to value. Workflow integration friction is the second barrier. If a tool disrupts clinical rhythm, adds steps that already exist elsewhere, creates duplicative work, or forces people to find workarounds. The technology may be impressive on a slide and useless in practice. This is where process debt gets dangerous. Many healthcare systems still run on fragmented legacy workflows. If you layer AI on top of broken processes, you amplify the problems instead of solving them. So before asking what AI to buy, ask which workflows are ready to be augmented. That question protects your investment. The third barrier is organizational readiness at the leadership level. Most executive teams understand AI matters. Fewer are prepared to govern it well. Leadership fluency with AI is now a strategic asset. Not because every executive needs to code an algorithm, but because leaders must make disciplined choices about risk, sequencing, accountability, and measurement. Governance cannot be handed off entirely to IT. AI in healthcare touches safety, ethics, compliance, finance, operations, and reputation. Governance must be cross functional by design. So, what does good governance look like? Start with four pillars. 1. Regulatory compliance. If the use case is clinical decision support, confirm the algorithm aligns with FDA expectations and applicable guidance. 2. Patient privacy. Ensure HIPAA compliant pipelines, clear controls on data handling, and explicit rules on ownership and retention of AI generated information. 3. Model fairness. Audit for bias across ethnicity, socioeconomic status, and population representation. If your data is skewed, your outcomes may be too. Define validated performance metrics. Clarify human accountability. AI may inform decisions, but accountability cannot become ambiguous. Then add the enterprise security layer. AI introduces new attack surfaces, that means vendor assessment protocols, model security reviews, and end to end data provenance tracking are no longer optional. This sounds heavy because it is, but this is the cost of responsible scale. And responsible scale is what separates strategic transformation from uncontrolled experimentation. One executive truth sums this up: AI succeeds in healthcare when technology, workflow, and governance mature together. When one lacks, value stalls. When technology outruns workflow, clinicians push back. When workflow outruns governance, risk grows. When governance outruns execution, momentum dies. Your role as leadership is keeping all three aligned. Result? Transformation that sticks, not a collection of fragmented pilots. So here is the verdict. My recommendation is simple: deploy, prepare, observe. Deploy targeted pilots now in high value, lower risk workflows. Prepare the organization through governance, security baselines, clinician engagement, and leadership education. Observe relentlessly through shadow mode, baseline measurement, outcome tracking, and fairness auditing. And then scale only the systems that prove three things: operational fit, clinical trust, and measurable business value. Do not wait for perfect clarity. Healthcare will not get that luxury with speed alone. The winning move is disciplined acceleration, because over the next 12 to 18 months, AI maturity will begin to separate healthcare organizations into two groups: those building strategic advantage through structured integration, and those accumulating integration debt while hoping to catch up later. One path compounds capability, the other compounds complexity. If you are in the C suite or on the board, this is the moment to decide which path you are funding. AI is not replacing healthcare leadership, but healthcare leadership that understands how to integrate AI responsibly will absolutely outperform leadership that does not. That is the real strategic signal. See you in the next one.